definitely within oncology care, there's a role for NGS in the identification and management of both solid tumors and hematologic cancers. And this role is likely just going to continue to expand. So really, there's been an increased focus on genomic-focused pharmacotherapy and targeted therapy, and this is playing an ever greater role in the treatment of cancer. So NGS will really continue to serve as a means to take a closer look at the patient's cancer at the molecular level and hopefully match patients with treatments that will be most effective at treating their cancer.
You're listening to the Oncology Nursing Podcast, where ONS Voice talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we are talking with Danielle Fournier, Advanced Practice Registered Nurse in the Department of Thoracic Surgery at MD Anderson Cancer Center in Houston, Texas, about using next-generation sequencing technology, which we will be calling NGS, to help care for cancer patients. This episode was produced by ONS and sponsored by Foundation Medicine. Thank you for joining me today, Danielle.
Thanks so much for having me. I'm a big fan of your podcasts, and I'm excited to be here today.
Great. So this is a really very interesting topic, and one that is just gaining a lot more attention and always changing, kind of one of those exciting areas of oncology that it's changing so rapidly and new things are being discovered using next-gen sequencing. Just start us off. Can you explain what is NGS?
Next-generation sequencing is a now commonly used DNA or RNA sequencing technology, which can be used to help identify genetic variants that are associated with a cancer diagnosis or other diseases. Before we talk a little bit about NGS, I think it's important to kind of talk about what came before it. So Frederick Sanger is really credited with much of the early work in DNA sequencing, and his work in the 1970s used radiolabeled and partially digested DNA fragments to develop what's known as the chain termination method. And this method, which became known as Sanger sequencing, was used to sequence the first ever complete genome, and this was really the dominant DNA sequencing technology in use for about 30 years. While this method could be used to sequence an entire genome, it was typically used to sequence kind of smaller, more specific DNA regions because it had a pretty high cost and a long turnaround time. But in the 1990s, there was a group that developed a new DNA sequencing technology called pyrosequencing, which measured basically luminescence generated during pyrophosphate synthesis during the DNA sequencing process. And this was released as an automated system in 2005. And this was really considered the first next generation sequencing system that was available on the market. The testing technology has really taken off from there. The main differences between next generation sequencing and Sanger sequencing are primarily related to sequencing volume, sequencing length, and overall cost. So Sanger sequencing could really only sequence one single, DNA fragment at a time, versus NGS can read millions of DNA pieces within the sequencing system simultaneously. And so for that reason, you may hear NGS referred to as massive parallel sequencing. They're kind of used synonymously. This helps to speed up the sequencing process tremendously. So NGS methods, compared to Sanger sequencing methods, NGS methods usually read shorter fragments of DNA, which are about 100 to 200 base pairs long, whereas Sanger sequencing can read sequences as long as 700 to 1,000 base pairs. And because of the high throughput feature of NGS, it's much more cost effective than Sanger sequencing when you're trying to sequence a large amount of DNA. So you may kind of be asking, how does NGS work? It's definitely a complex process, but I'll give you a quick overview here. It involves a couple key steps, which include sampling, DNA library preparation, amplification, sequencing, and data analysis. NGS can be performed on any sample containing DNA or RNA, which primarily stem from either blood, saliva, bone marrow, or tumor tissue. These are usually the most commonly used samples. Once the DNA or RNA is obtained, then you enter the DNA library preparation stage, which DNA from the sample is basically cut into short strands using either mechanical, chemical, or enzymatic methods. They do this because short DNA strands are much easier to sequence. So each end of each of the fragments is then enzymatically linked to what's called an adapter, which is a short strand of engineered DNA. And this is basically serves as the primer binding site during the next phase, the sequencing phase. So once all that's done, the DNA library is loaded into a flow cell, which is kind of just a hollow glass slide that has multiple channels, and it's placed in the sequencer, the machine. The adapters will bind to complementary oligonucleotides that are attached to the flow cell. And then each library fragment is cloned, resulting in millions of copies of single-stranded DNA that can undergo the sequencing process. During each sequencing cycle, there is a fluorescently tagged nucleotide that's added to the chain. And after each nucleotide is added, the fluorescent dye is imaged to identify which base pair was added. So nucleotide base calls are made based on the signal measurement in each cycle. And this is repeated until the full sequence of the DNA or RNA of the bases in the fragments is determined. So once all of that is done, then basically the last step is analyzing the base pair sequence. And the most important part of this step is comparing it to a reference genome to identify any genetic variants that may be present in the sample. That's a lot of information to digest right off the bat. The good news is most of this work happens behind the scenes in the lab, and it's not something that nurses are directly involved in. I still think it's kind of important to have some baseline knowledge of this process. And hopefully in our discussion today, the listeners will get a better idea of how the results of NGS testing can inform clinical practice decisions.
Thank you, Danielle. That is very detailed, but great information. It is good to understand kind of what the process is and what they're looking at and what nurses can at least try to understand how this all works. Can you explain to us how NGS differs from other biomarker testing technologies? Because there are so many different tests out there, and as nurses are working with patients, they might come from a different location to where they are now. And, they might have had some types of testing done at their primary oncologist office, but now they're coming to a larger academic center and they might have to have some different testing done. So can you talk about what some of the other biomarker testing is?
Definitely. So I've already talked a little bit about how NGS differs from Sanger sequencing, which is still in use, but there are other testing methods that can be used to identify biomarkers found on tissue. Some of these that you may have heard of may include fluorescence in situ hybridization, also known as FISH, or immunohistochemistry, also referred to as IHC, or real-time PCR. I'll quickly kind of go over these. So FISH basically exposes chromosomes to a small DNA sequence called a probe, which has a fluorescent molecule attached to it. This probe then binds to its corresponding sequence on the chromosome, and this method can primarily be used to test for biomarkers such as like an ALK translocation, MET, RET, or ROS1. Alternatively, immunohistochemistry uses antibodies to check for certain antigens in a tumor sample. And the antibodies are typically attached to either an enzyme or a fluorescent dye. And then once the antibodies bind to the antigen in the tissue sample, this basically activates the enzymes or dye so that they can be seen under the microscope. And commonly used biomarkers that can be identified using IHC include BRAF, HER2/neu, MET, PD-L1, or microsatellite insufficiency. So the other one I'll cover is just real-time PCR, which is a very highly sensitive and reliable technology that can be used to identify genetic variants. It can be used to quantify the expression of a few genes, although a limitation is that it can only detect known sequences. So real-time PCR is typically a good choice when the number of genetic regions you're wanting to target is low, ideally less than 20, and when the goal is limited to screening or identifying known variants. So one of the benefits of NGS, though, compared to some of these other testing technologies, is that with NGS, multiple biomarkers can be evaluated using one test. So in cancer care, we're learning that any given tumor may harbor a variety of mutations. So if we're considering using IHC or FISH to identify biomarkers, multiple assays may be needed and may need to be performed in order to test for multiple variants. And this can amount to the need for a larger amount of tissue in order to run all these tests. So this can really be a major obstacle if the patient has a limited amount of tissue that's available from a previous biopsy. So definitely one of the benefits of NGS is that we can sequence a few to several hundred genes with one test and with a limited amount of tumor tissue. And this can potentially avoid the need to have to perform a repeat biopsy to obtain more tissue.
Thank you for explaining the differences. I think that in our listeners, we've got new nurses right out of school. We've got new to oncology nurses. So some of those different testing technologies may be familiar. They may have heard of them, but it's good to get just kind of an example and talk about what those differences are.
It's definitely complex, but having an understanding of what some of the testing options are, I think is valuable, especially when you work in oncology care.
Exactly. So now that you've kind of explained the differences in the different types of testing technologies, when would a healthcare provider elect to use NGS?
There's multiple testing strategies that can be used with NGS technology, which is kind of what makes it so versatile. So what type of testing is most appropriate really depends on the patient's risk factors, their diagnosis, their cancer stage, what testing has been previously completed, and what tissue is available for analysis. So NGS can be used for single gene testing, although really there's been a shift in recent years towards a more multi-gene panel testing approach, which usually then involves sequencing either dozens to hundreds of targeted genes. These targeted NGS assays are really designed for a specific cancer diagnosis or disease. For example, a panel may be designed for evaluating mutations typically associated with acute myeloid leukemia, or a panel that's more specific to non-small cell lung cancer. So multi-gene panel testing obviously provides a lot of valuable information and more information than a single gene panel would, although it may also increase the likelihood of identifying a variant of uncertain potential, which may lead to patient confusion when there might not be a treatment decision that can be made based on their testing results. So aside from multi-gene panel testing, they can also use whole exome sequencing, which involves basically selective sequencing of the protein coding regions of the genome. And this represents about 1% of the human genome. Whole genomes or whole exome sequencing is typically more cost effective than whole genome sequencing. Although when we're analyzing larger amounts of genetic material, there's increased risk for detecting unknown variants, and this can lead to complex kind of clinical interpretation of the findings. Of all of these testing techniques, the most comprehensive would be whole genome sequencing, which would analyze basically the bulk of an individual's DNA to identify genetic variations. Downsides of this strategy is that it is the most expensive testing option, and it makes clinical interpretation more time-consuming, and some of the data may have indeterminate clinical value. At this time, we don't really use whole genome sequencing commonly in the clinical oncology setting, but it can be used to guide cancer research. So it is something that is used from time to time. But when it is used in clinical settings, it's more often for constitutional genetic diseases rather than, say, identifying cancer somatic mutations. The last one I'll kind of talk about is liquid biopsies. So cell-free DNA and liquid biopsies have grown in popularity for cancer diagnostic testing. And we know that all cells, both cancerous and healthy cells, shed DNA into patient circulation. So This cell-free DNA can be isolated and analyzed by next-generation sequencing for a variety of purposes, including identifying circulating tumor DNA, which can be used to detect somatic variants from the patient's tumor. Additionally, cell-free DNA is also being studied as a marker for residual cancer burden, as well as response to therapy, as well as prognosis. So, benefit of this approach is it gives clinicians the ability to get more genetic information, which can help to guide treatment decisions while avoiding the need for an additional invasive procedure to obtain more tumor tissue. So ultimately, the healthcare provider needs to take into account kind of the individual information about the patient when they're making a decision about what type of testing is right for the patient.
Thank you. So now that we've talked a little bit about why a healthcare provider would elect to use NGS, and you have kind of mentioned what some benefits are to the different types of testing technologies, can you talk about the benefits specifically of NGS for us?
I think the clearest benefit is that it's cheaper and faster than its predecessor, Sanger sequencing, since it can sequence thousands of genes or gene regions simultaneously. And since it requires less time and manpower than Sanger sequencing, the costs are much lower. So that's definitely a benefit from previous testing technologies. But again, it needs significantly less DNA in order to perform testing. So that's definitely a benefit. And then overall, it's more accurate and reliable than Sanger sequencing and can identify genetic abnormalities across the entire genome. So that's a huge asset as well. So really, due to the comprehensive nature of NGS, there's also the potential it can identify novel actionable targets. So it plays a role in, as I kind of mentioned, cancer research as well.
Great. Well, we've talked about benefits, so let's talk about limitations. Are there limitations to this?
Definitely. So nothing is perfect yet. There's still definitely room for improvement here. Turnaround time continues to be a limitation, as most NGS testing can take anywhere from usually about 2 to 3 weeks. And while providers typically feel like the benefits of waiting for results outweigh the risks, given the potential identification of an actionable mutation is typically associated with better survival outcomes, this does mean a potential upfront delay in initiating care for patients, which they aren't always excited about. NGS may not be as accurate as some of the other testing methods. In particular, if there's been large gains, losses, or translocations, NGS isn't always the best technology to pick up those genetic changes. So there are other alternative testing methods available, such as comparative genomic hybridization, microarray, FISH, which we talked about, or cytogenetics, which may be preferred over NGS for those situations. In some cases in which the patient's primary biopsy was performed years ago, maybe before they developed more advanced disease, this tissue may not be in a good enough state to perform NGS testing on. And some studies have suggested that DNA that was extracted from cancer tissue more than 7 years ago are not adequate for NGS analysis. In these cases, fresh biopsies oftentimes need to be done in order to get updated tissue, or may consider NGS via liquid biopsy if that's appropriate. Due to the thorough nature of NGS sequencing, testing may identify what's known as a variant of uncertain significance, or a VUS, which I kind of referenced, but these are basically genetic variants whose significance is not really yet fully understood. So these may potentially represent pathogenic mutation, which increases the patient's risk for cancer or other disease, or it could potentially be benign and harmless. We just don't have enough information at this time to know. Unfortunately, up to about 40% of variants that are identified through NGS may be characterized as a VUS. So this can leave patients feeling confused if it's not associated with any actions that guide the plan of care. As researchers learn more about these variants, they may be reclassified, but that could take years. So that can leave patients feeling frustrated if this is a finding on their testing and they don't really have necessarily a clear plan based on those results. And then one last note is, while costs have come down significantly that have made NGS testing more accessible to patients, on average, the cost of a targeted gene panel sequencing is still about $1,600. And this can range from anywhere from $500 to $3,500, which, depending on insurance coverage, can potentially be a hefty bill for patients. So The good news is, as biomarker testing recommendations have been adopted as standard of care into many national cancer treatment guidelines, either by NCCN or other organizations, there's definitely less pushback from insurance companies to cover the cost of NGS testing, but this is still something that can have huge financial impact on the patient and needs to be investigated by the patient and healthcare team to ensure that the patient's not left with a huge bill.
Thank you for that. Not only are nurses learning about all of the new testing that is coming out, as well as new treatments and things like that, but our patients are also reading things on the internet and hearing things from friends and family and things like that. But as we know, all treatments are not appropriate for all patients or all diagnoses. Is there a specific patient population that benefits from NGS?
Yes, definitely within oncology care, there's a role for NGS in the identification and management of both solid tumors and hematologic cancers. And this role is likely just going to continue to expand. So really, there's been an increased focus on genomic focused pharmacotherapy and targeted therapy, and this is playing an ever greater role in the treatment of cancer. So NGS will really continue to serve as a means to take a closer look at a patient's cancer at the molecular level and hopefully match patients with treatments that will be most effective at treating their cancer. In terms of management of solid tumors, the NCCN guidelines do have biomarker testing recommendations for a variety of solid tumors. So these currently include lung cancer, esophageal cancer, colorectal cancer, breast cancer, melanoma, gastric cancers, thyroid and ovarian cancers, and this is among others. This list is just continuing to grow. As far as managing hematologic malignancies, NGS can also provide some meaningful information. What we're learning is that the genetic makeup of leukemias, lymphomas, and myelomas is really critical in their diagnosis and treatment, and that NGS can help to identify common variants that have prognostic value as well as clinical importance in these diagnoses. NGS technologies have been applied to heme malignancies in a variety of different ways, including determining the subclassification of a leukemia or lymphoma, determining prognosis, as well as determining if there's minimal residual disease while the patient's undergoing treatment. NGS is also helping to identify novel mutations that may open the door to new drug development for any of these diseases. For patients who are considered high risk for hereditary cancer syndromes, NGS can also help to diagnose a germline mutation, and in many cases, multi-gene panels for certain inherited cancer syndromes are becoming increasingly popular to make these diagnoses. Really, for the sake of this podcast, I'm primarily focusing on the use of NGS in cancer care, but in reality, there's an expanding role for NGS testing in the diagnosis of many complex diseases. And so I think more than likely what we're going to see is that the indications and utility of NGS is only going to continue to grow both in the oncology setting as well as the non-oncology setting.
Excellent. Thank you for that. I think it's important to know what patient populations these types of testing are used in because we may have patients come in and say, that their neighbor had this done and why can't they have it done? Or just understanding the ways that different types of testing technologies are used. So we've talked a lot about specifically the NGS testing and those kinds of things. Can you tell us a little bit about what is the oncology nurse's role in NGS testing?
I've talked a fair amount about kind of the NGS process that goes on behind the scenes, but the oncology nurse really plays a key role in several important steps along the way. So the first place they may be involved is in the informed consent process. Many, but not all hospitals require patients to sign consent for genetic and genomic testing. And this really is just acknowledging that the patient's making an informed and autonomous decision related to their health care. Because of, some of the complex issues and implications surrounding genetic testing, providers and genetic professionals usually will provide genetic counseling in the way of education, guidance, as well as some pre- and post-test information about the risks, benefits, and limitations, as well as the implications for the test results and the possibility of also incidental findings. So the nurse may be involved in obtaining informed consent and involved anywhere along this process. I will just also mention that there is an International Society of Nurses and Genetics. This organization is called ISONG, and they do have a position statement on the role of nurses in the informed decision-making and consent process related to genetic testing, which is available online. So I won't go into that in detail, but they do a nice job highlighting how they foresee the role of the oncology nurse kind of in this process. After informed consent's obtained, nurses may also play a role in the collection of a tissue sample or a blood sample, which can be used for testing. The key components of a proper specimen collection are verifying testing orders, providing some patient education, following collection protocols that are specific to the type of specimen that's needed, definitely appropriately labeling the specimen for analysis, and then ensuring safe delivery of the specimen to the lab. So the nurse may be involved in this process. Being mindful that following appropriate protocols can help to reduce the need for repeat specimen collection, which could potentially delay patient care or treatment. That's something that detail-oriented nature is definitely important in this process. And then once testing has been completed, nurses may play a role in discussing the NGS results with patients. So I think it is important that nurses should be able to understand some of the basic findings on the NGS test results and understand what some of the implications may be for the patient's cancer treatment, because these are oftentimes the questions that they may get asked from the patient. They may also want to help provide some patient and caregiver education, and may also be there to provide some emotional support regarding the test findings.
That's good for all of our listeners to know kind of what their role is and how they should prepare for this. So you talked about being able to review or understand the NGS test reports. Can you tell us what should the nurse consider when they are reviewing those reports?
Yeah, absolutely. So there are numerous companies that currently offer NGS testing. There may be slight differences in the NGS report in terms of formatting, but typically across companies, there will be some similar content. So I'll spend a few minutes going over what you can expect to find in the report and its clinical significance. Most importantly are there any actionable variants? So the report will show if there's any variants or mutations that are identified that have a clinical utility. And this may tell the provider if that will be predictive of maybe response or non-responsive to certain cancer therapies. If a variant is identified, it will also likely include its classification, which helps us to determine its clinical significance. Variants are typically classified into 4 tiers based on evidence from the literature. Variants in Tier 1 have the strongest clinical significance and are usually associated with an FDA-approved therapy, while variants on the other side of the spectrum in Tier 4 are likely benign. So they'll typically provide a classification for the variant if there's one identified. Along those same lines, if there is an actionable variant detected, the report typically will indicate if there's an FDA-approved therapy for that particular variant. So this would indicate what cancer therapies are approved to treat tumors that harbor this variant in patients with the same diagnosis. Some reports also indicate if there's therapies that are not likely to be effective, and this may either be due to known resistance mechanisms associated with that particular variant or other reasons as well. So those may be listed. Some reports also include a list of FDA-approved therapies in different cancer types. As you know, some variants can be found in multiple cancer types. So an example of this would be HER2 in both breast and esophageal cancers, or BRAF in both lung and thyroid cancers. This section of the report would indicate if there's been any FDA-approved therapies to treat the actionable variant in other cancer types, and this may have implications for off-label use. The report might highlight clinical trials that are available to the patient given their diagnosis and the presence of actionable variants, and these may include basic information about the trial or provide a link to access more information about the clinical trial. There may be a section on immunotherapy biomarkers, including measures such as tumor mutational burden or microsatellite insufficiency status. And these markers can help predict response to checkpoint inhibitors and are increasingly important in treatment decision-making, especially in the last couple of years with the advent of immunotherapy. Reports may list prognostic or diagnostic variants, which are identified as part of the NGS testing. And sometimes these variants can provide input on the patient's risk for disease relapse or survival. So they're important to note in some cases. When a patient's undergoing somatic mutation testing, NGS may kind of uncover genomic variants on the tumor tissue that prompt further germline testing for hereditary cancer conditions. So these can be listed on the report under a section that's usually titled Variants to Consider for Further Germline Testing. And then variants of uncertain significance, which we've talked a little bit about, that don't have any current evidence for their either therapeutic or diagnostic utility, may be listed as well. And these, again, may be reclassified in the future, but it may be important for the patient to know that they harbor this particular mutation, but we just don't know enough about it right now. And then lastly, typically the report will include a list of all genes that were tested to know what all was evaluated. So this is really kind of just a basic overview of what the nurse can expect to find on an NGS report. In no way does the nurse need to have a comprehensive understanding of what every little finding will mean, but I do think it's important for them to have a broad understanding of the importance of each of these sections and how these may impact the patient's care.
Danielle, thank you for explaining that. So many important pieces that will be on that report that the nurse can look at and or look for when they are reviewing these reports. So since you talked about how on the report there are places where it might indicate treatments that are appropriate or not appropriate, can you give us a case example of a patient that their treatment trajectory was altered because of what was discovered through the NGS?
The early uses of NGS were typically more limited to patients with unresectable or metastatic disease. In my current practice, I work in the lung cancer setting, so I'll kind of approach this with that frame. In particular, in the lung cancer setting, targeted therapy and immunotherapy were initially really just approved for patients with advanced disease. So these were the patients who underwent biomarker testing with NGS or other modalities. But what we're seeing, though, is that there is actually an expanded role for treatment with targeted therapy, even in earlier stage lung cancer. So a recent study where a trial was a double-blind phase 3 study, and it looked at the use of osimertinib, which is an EGFR tyrosine kinase inhibitor, compared to placebo in the adjuvant setting after a patient early stage lung cancer underwent surgical resection if their tumor harbored an EGFR variant. The results from this study showed that disease-free survival was significantly longer for patients who received osimertinib than those who received the placebo. Based on these findings, they did update recommendations that patients with stage 1B to 3A non-small cell lung cancer should have biomarker testing to identify if their tumor has an EGFR variant. And then these recommendations have been updated in NCCN. So in alignment with this recommendation, we've started performing NGS testing to identify if a patient has an EGFR variant for eligible patients who are undergoing surgical resection of their lung cancer. One case that comes to mind is a 72-year-old gentleman. He's a never smoker, just underwent a cardiac CT for calcium scoring and was incidentally found to have a 2.6 centimeter right upper lobe mass. His further staging workup was negative for lymphatic spread or distant disease. So he underwent surgery. He had a right thoracotomy, right upper lobectomy, and mediastinal lymph node dissection for his upfront cancer treatment. Ultimately, his pathology showed he had a 2.8 centimeter moderately differentiated adenocarcinoma with visceral pleural invasion as well as lymphovascular invasion. And both of these are considered poor prognostic features in lung cancer. But there was no evidence of nodal disease in the lymph nodes that were resected from surgery. So his pathologic stage was stage 1B. In the past, patients with stage 1B lung cancer with poor prognostic features, standard of care would have been 4 cycles of chemotherapy to help reduce the risk for and eliminate micrometastatic disease. But these patients, somewhere in the order of about 30 to 60%, still would end up developing recurrent disease. So this gentleman underwent biomarker testing with NGS, and he was found to have an EGFR mutation. So he did go ahead and complete 4 cycles of doublet chemotherapy. but then was initiated on adjuvant osimertinib once the chemotherapy was complete, which he'll continue on for a total of 3 years. I don't have long-term data on this patient's particular clinical outcome, but really based on the data from the ADAURA trial, somewhere on the order of at 24 months, about 89% of patients who received osimertinib were alive and disease-free, compared to only 52% of patients who received the placebo. So this really, to me, suggests that through NGS testing and identification of actionable biomarkers, especially when there are targeted therapeutic options available, this can really have such a meaningful impact on patient survival.
Thank you. That was a great example for how it's used and how it can really impact a patient's treatment. What would you recommend for how an oncology nurse can educate their patient on NGS?
I think having a general understanding of the NGS testing process, nurses can help their patients to understand what's involved in testing, what is the clinical value of the results, and these are probably the most important takeaways for the patient. One of the frustrations that often comes up for patients is that testing can take 2 to 3 weeks to get the results, and they really might not understand why we would recommend waiting for that amount of time to get the results instead of moving forward with treatment. Certainly, new cancer diagnosis is an anxiety-ridden time for patients, and they're usually eager to kind of get a plan lined up. So nurses really can help to somewhat bridge this information gap and help patients better understand that the information received from NGS can really help to determine which treatment they will respond best to, if there's therapies that won't be effective, or if there are clinical trials that are open to them based on the results. And these are all really important considerations for cancer treatment. I think it's important to highlight, that using this mutation-focused approach can improve progression-free survival, and that targeted therapy often has fewer side effects than kind of the traditional one-size-fits-all chemotherapy approach. So hopefully putting this information in this light can help patients see why we don't always rush into starting therapy if it's not an emergent need to initiate treatment quickly, but getting the right information to help make these treatment decisions.
Danielle, this has been a really interesting podcast. You have given us so much information about NGS and how it's used with patients and what nurses need to know about this. It's just been really fascinating. And we're coming to the end of our time. So there are a few questions that I always ask, and I want to ask those to you now. And the first one is, what are common misconceptions about NGS?
I think probably one of the biggest misconceptions is that patients fear, that the results of their genetic testing could be held against them in some way. So patients may ask, could I lose my health insurance, or will my insurance premiums increase if my genetic test comes back positive, or could I be fired if my employer finds out I'm high risk for cancer? These are things that weigh on patients' minds. So I think it's important just to point out that patient health information, including genetic testing results, is protected under HIPAA, as well as the Genetic Information Non-Discrimination Act, which is known as GINA. GINA involves regulations surrounding the collection and use of genetic information, as well as prohibits genetic discrimination. And they define genetic information pretty broadly. It's including not only genetic test results, but any genetic services, such as a consultation with a genetics professional that the patient may receive. It does prohibit health insurance plans and employers from requesting, requiring, or collecting genetic information on an individual or their family member. The only exception is that a health insurance plan may request the results of an individual's genetic testing if they're trying to determine coverage for a procedure. So an example of this might be if there's a woman with a BRCA1 mutation who's requesting either annual breast MRI or a prophylactic mastectomy due to her increased lifetime risk for breast cancer. Her insurance company may come back and say that they need to see a copy of the BRCA1 genetic test results to confirm she is truly high risk. So definitely there's protections in place via GINA. And then when the Affordable Care Act was passed in 2010, patient protections under GINA were further strengthened because this legislation prevented individuals from facing health insurance discrimination on the basis of a pre-existing condition. So while patients who maybe have a hereditary cancer or have a gene that is positive for hereditary cancer syndrome who have not manifested any cancer diagnosis would have been protected under GINA if they were to have developed a breast cancer with a BRCA1 variant that could be considered a pre-existing condition before the passing of the Affordable Care Act. So between these two legislations, both pre-symptomatic and symptomatic individuals are protected. I think it's really important for nurses to know there are significant protections in place for patients so that they can help to dispel any concerns that patient may have related to potential discrimination on the basis of their test results. And that could impact the patient's decision on whether to proceed with testing or not.
Thank you. What's something about this topic that's not often discussed, but you wish people knew more about?
We've covered a lot. So what comes to mind is I kind of mentioned that NGS is being used outside of the cancer care setting in more and more ways. So in one setting, it's been incorporated into the National Institute of Health's Undiagnosed Diseases program, which is basically a program that primarily evaluates patients who have either a longstanding medical condition that's gone without an official diagnosis or have had symptoms that just have never been able to elicit a diagnosis. So they did one study of patients followed in this program, and in a study of about 380 patients who were followed in this clinic who completed either whole genome or whole exome sequencing, 132 of them were able to receive a diagnosis, and the majority of these were based on their sequencing results. I think this just goes to show that NGS really may help to play a role in the diagnosis of complex diseases outside of the cancer care realm at the present and in the future. And then I thought this was interesting too, that there are other uses of NGS, which include the identification of an unknown infectious pathogen that could not be identified using other testing modalities. And then NGS was also, a pretty big role in the development of the COVID-19 vaccine, including identification of the viral sequence, characterization of the viral structure, as well as vaccine design. So I think we'll continue to hear more and more about potential applications for NGS in really many different settings in medicine.
What additional training or education do oncology nurses need to better assist them in understanding NGS?
NGS testing is here to stay. I think it will be increasingly important for oncology nurses to have a basic understanding of what this testing is, how it works, and how it can impact cancer care clinically. I think as we see the use of NGS grow within and outside of cancer care, it'll be more important to incorporate a lot of genetic and genomic education foundations within formal nursing education. This has supposedly been a priority for many years, but despite efforts to improve genetic and genomic education, there really hasn't been a lot of progress. So I think in order for nurses to be able to engage with other members of the multidisciplinary team about genetics and genomics in a meaningful way, they need to have a pretty solid knowledge base. So I definitely foresee room for improvement here.
And lastly, what are some additional resources for both patients and providers who want to learn more?
ONS has developed a number of educational tools to help nurses and patients better understand the impact of NGS testing on cancer identification and management. And these are available through the ONS website. We've also adapted a sample next generation sequencing report so that nurses can familiarize themselves with the information that's often included on this report and its clinical impact. So those are all accessible through the ONS website. Additionally, I'd say the ONS biomarker database, which was just released this spring, as well as the NCCN biomarker compendium, both can help nurses stay up to date with biomarker testing recommendations, since these are constantly changing. Other than that, there's a lot of good information on each of the testing company and NGS platforms' websites, and this typically includes information for both healthcare providers and patients. So this is another great resource. And then I would say don't discount YouTube either. There is one channel that I have found particularly useful called Seek It Out, which is spelled SEQ. And this has a slew of videos which provide a great overview of the next generation sequencing testing process, as well as a variety of videos related to other NGS testing topics. So these are all great options.
Danielle, again, thank you so much for being with me today and for everything that you provided in our discussion. It was extremely valuable and informative, and I think that our listeners are really going to appreciate our discussion. So thank you. do you have any final comments for us?
Thanks so much for having me. There's no doubt in my mind that NGS testing is here to stay. We've come a long way since this technology was introduced in 2005. So I wouldn't honestly be surprised as far as future directions as the cost of sequencing continues to decrease, as well as our ability to identify actionable variants improves, that whole exome sequencing and whole genome sequencing may gain more traction over multi-gene panels in the future. But this is not the current practice as of yet. In any case, like I said, I think NGS will just really continue to expand its role in all facets of cancer care. I think this really just stresses the importance of nurses to build a good foundation and knowledge related to genetic and genomic sequencing. And I think one of the hardest things right now is that NGS guidelines are constantly being updated as we learn more and new evidence comes out as far as cancer management. So it can be difficult for nurses and healthcare providers to stay up to date with current recommendations. Knowing what resources are out there is really key.
Thank you. And before we end today's episode, I want to take a moment to let our listeners know that I am moving on to a new opportunity and will no longer be your host of the Oncology Nursing Podcast. I've had so much fun talking with all of our guests on the show. It has been such a pleasure to share knowledge, insight, and stories with you, our listeners. But don't worry, I will be leaving the podcast in good hands with our team at ONS. Thank you all for listening and all of your supportive comments. It's not goodbye, but see you later. Take care, Stephanie. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.